all those patients routinely 2 years out. Usually the surgeons sign off after 3 months, but this is a wake-up call for all of us. And then another recent study, odds of getting AKI 4 times greater within 3 months of ileostomy creation, new CKD 2 times greater without an episode of AKI, and 5 times greater in those with an AKI event. This is, you guys, this is big stuff. This is people's kidneys. So why is this? Dehydration may not show up and probably doesn't show up until after discharge for these reasons. Those of you who work in the hospital, you've seen this. I've seen this many times. IVs are running up until discharge. They decide to discharge the patient today, like all of a sudden, undo the IV, out the door. So of course they look like a rose at discharge. Post-op intake is often very poor, and it is hospital food. Let's be real. And that poor intake may continue afterwards. So it might not be what they're eating or how much they're eating. It may be they're not eating or drinking enough. And then finally, the decreased length of stay with ERAS protocols. Some of our patients go home in 3 to 4 days after new ileostomy. And it's these unintended consequences we're seeing with some of the ERAS protocols. Yes, ERAS is fabulous, but at the same time, these patients go home so early, their output hasn't really been realized in terms of the total volume. And then this happens, this typical and very poor intervention. And I see these patients in clinic. They're told, oh, just drink more, okay? If they're coming in dehydrated, just drink more. The problem is in some of these patients, it dramatically increases their losses, and that just further dehydrates the patient. Then there's the patient that discovers, hey, if I drink less, I don't have to empty my ostomy appliances often. This is really a great way to control this. And as they go on, their kidneys get into trouble. And then finally, there's that patient that thinks, oh, I'm putting out and I need to just drink a lot. And this is a patient I saw in clinic, okay? Whenever I meet patients, I always ask for their baseline. They get homework. I want to know what you're drinking, eating for 2 days. So she comes in, her baseline oral fluid intake, oh my gosh, she needs scuba gear. Who can drink this much? And then her ostomy output was 3,600 mils a day. And her urine output was also way higher. So she lives in the bathroom, okay? 2 weeks, I said, drop it a liter. I want you to drink 3,500 mils a day. So she comes in 2 weeks later, she's oral intake, she did as I asked, and her output is down about 700 mils. Her ostomy output, her urine output is down still, fine within normal limits and safe. I said, cut it down more. So she does, drop her down another 500. Urine output is still just fine. So I said, take it down some more, and so again, she wanted to be very careful about this because she was so used to drinking so much. That's why she went so slow. I usually go faster than this. And as long as we're maintaining the targets for urine output, we're safe and we're good. So this was just in 6 weeks period. It was just by getting her to drink less. And some patients, that's what you have to do. Okay, why do we treat high output ileostomies? Because we want to protect people's kidneys. It's really that simple. We also want to decrease, another bonus is to decrease that readmission rate. Talk about where dietitians can make a huge difference for healthcare costs and utilization and really, really look good for administration. It lowers those because hospitals that have high readmission rates in less than 28 days for their Medicare patients, they get lower payments back to the hospital, and they also get labeled as a high-risk adjustment facility. So it's like their care isn't as good. They don't want that. And then, of course, from our perspective as clinicians, we want to lessen the burdens of our patients, which are they have a low urine output, so they're dehydrated. They can have electrolyte imbalances. They make kidney stones if they don't have enough urine, some of these patients. And then we could put them into AKI, which ultimately becomes CKD, and some patients end up on dialysis. I'm actually an expert witness in a case right now. It happens to be a short bowel case. The people who are watching managing her didn't hydrate her enough, and she ended up on dialysis for no good reason. These patients can have frequent leakages around their ostomy appliance, and then they get skin irritation. Again, the tiredness with the dehydration. And of course, these patients, if they're putting out so much, they can't go out because they can't risk their bag breaking or whatever. So it really affects overall quality of life. So what are the clues that your patient may be dehydrated? I'm sure you all have heard this, but anyone who's not making enough urine, and I define that as less than 1,200 mils a day, that is my target. If they're putting out over 1,500 mils of stool a day, that they're at risk for dehydration. Dark urine. I also want to know, when I meet these patients, have they ever been had a dehydration admit? Have they been to the ER and gotten IV fluids? Often that's your tip-off. Have they had kidney stones? Is their creatinine increasing because their kidney function is tanking? They're thirsty. They have a rapid weight loss. No one loses weight faster than those that are becoming dehydrated. These patients are very tired. They get hypotensive. They get orthostatic hypotension. They get dizzy. They can have muscle cramps and headaches. The reasons why these patients might have high output, occasionally it's an intra-abdominal sepsis. That brings them back. That can't be fixed by us just hydrating them better, obviously. Some of them actually have more bowel loss than they originally thought they'd taken out, and they end up with a relative short bowel syndrome. They can have an enteric infection like C. diff. I've got an article that's coming out this year on C. diff and ileostomies, because there are a lot of clinicians that don't believe you can get C. diff with ileostomies. Au contraire. They may have carcinoid. This is a rare complication, not a complication. This is a rare thing that you're going to see. Some people just have recurrent Crohn's or another underlying disease that makes their output higher. Some patients have what's called overflow from a stricture or obstructive process. This is, in fact, what happened with the gentleman I presented with you at the beginning. He had a strictured, narrowed area in his ileum near his ostomy, and he had overflow diarrhea. And then there also can be the new medication initiation that causes more output, or a medication that actually decreases output has been taken away, or the patient has run out and they forgot to let anybody know to refill their prescription. What I have found is that we must educate our patients what to expect. I can't tell you how many patients I've met in clinic that when they report to me their output, and I'm literally horrified, and I say, well, what did you think you were supposed to make? And they say, well, nobody ever told me. I thought this is normal. So that, shame on us. So it's absolutely part of our education program now, you can be sure. And this is just for your information, what sort of you can expect with ileostomies. Jejunostomies, they're all over the place. But, a new ileostomy can be up around 1,500 mils, but it should settle out down to between 800 and 12. So when I meet a patient, first thing I want to know is their anatomy. I want to make sure I understand their anatomy. So I'll go for an op report if I've got it, or a reliable drawing that perhaps the patient was given to by their surgeon. Otherwise, we'll get a small bowel follow-through, and that also tells us the transit time, how long it takes for fluid to transit through their GI tract that's remaining. Abdominal CT can give us the information, and of course, I want to know the past medical surgical history in case that is complicating what I'm dealing with. And then I learned this the hard way. I work with a lot of very complex GI patients. Once I know their anatomy, it goes in the EMR at the top of their note, every single entry I make. And that's because I cannot remember all my patients' anatomy. The other thing is that clinicians who know me, if I'm involved in the case, they know they can trust that if I've got the anatomy there, that's what the patient's anatomy is, because I take the time to find out what it is. And so they can always go find one of my notes to find out what the anatomy is if they can't find it in the chart readily. I also want to know the patient's weight history. Are they stable Or are they, in addition to dehydrated, they're also malnourished, and that has to be attended to as well. I want to know baseline 24-hour measurements of both urine and stool. And I always, again, I'm going to repeat this throughout the talk, that goal urine output, can they make 1,200 mils or more? Any patient who has formed a kidney stone, they just bought a 1,500 mil target. These patients have already shown us they can form kidney stones, and any of you have had a kidney stone or know somebody who's had a kidney stone, they're awful. You don't want to have one. So you want to make sure they're making even more urine if they're a stone former. And then the stool output per 24 hours, our goal now is less than 1,200. Many institutions use 1,500. What I use is really what's noxious for the patient. If the patient's complaining with 1,200 mils out, I'm going to do what I can to actually get it less than that if possible. When I talk to the wound and ostomy nurses, I've spoken at a lot of their conferences, I will ask them, a lot of them will be called in to patients who have leaking pouches, and I'll say, please document in Epic if in fact that's going on. And the reason for that is that if I'm looking at I&O records in the patient's chart, and I've got these nice volumes, but the patient's actually leaking around and having to have multiple changes to their ostomy appliance, then that means that volume that's there is not at all what they're really putting out, and I may think I'm getting it under control when in fact they're just leaking all over the place. So I ask the nurses and the wound and ostomy nurses to please make note of the chart so I can make sure I'm looking at the information correctly. It's also less chance for dehydration why we set these goals, and it's so our patients have a life outside the bathroom. Okay, so when I get a high output, not a regular just your new end ileostomy, a high output ileostomy, I'm going to put them on what's similar to a short bowel diet. There's some data for this, but the main things I go after are I encourage the complex carbohydrates, super easy to digest and absorb. I ask them to avoid simple sugars, both food and fluids like the desserts and candies, etc. And definitely watch out for the sugar alcohols and liquid medications and the diabetic foods. For example, I'll often talk to them about the sugars and all that stuff. And I'll come by the next day and they've got pancakes and they're like, oh, I've got the diabetic syrup. It's okay, I can manage it. I'm like, oh my gosh, no, you don't want to have that because it has sorbitol in it, which is a laxative. So you want to make sure you make it clear, both sugar-free and diabetic foods you got to avoid. End ileostomies need more salt. They lose more salt, so they're going to need more salt. And in fact, they lose about a teaspoon of salt per liter. So I just tell them to use a salt shaker. I make sure they're not restricting salt and to eat salty foods. And a lot of them, it's like, oh my gosh, I've been restricting salt forever. So it's going to be a big change for them. And then as far as fluids, I ask them to avoid hypertonic. That's the juices, sodas, the high sugar drinks. And the limit hypotonic fluids I'm going to explain in a minute. And then oral rehydration solutions work well with these patients sometimes. Okay, what are hypertonic fluids? Those are fluids like the juices, sodas, sweet tea, syrups, ice cream, etc. Hypertonic fluids pull fluid from the bowel wall into the lumen to dilute it. The bowel wants to make everything in it isotonic. That's its job. Conversely, hypotonic fluids like water, tea, coffee, alcohol, diet drinks, those are hypotonic fluids. They don't have much in them. And so the bowel, again, wants to make it hypotonic. Well, to do that, it has to pull sodium from the bowel wall. Sodium never travels alone. Sodium will pull a water molecule with it, also increasing the volume of stool. Okay, so they get it going and coming. But the hypotonic fluids are the lesser of evils, and when I negotiate with patients, this is what I go for. The oral rehydration solutions are not a panacea. I think a lot of clinicians think that all they have to do is put their patients on oral rehydration therapy and it's a magic bullet and it fixes everything, and it doesn't. The other thing is a lot of patients hate these and won't drink them anyway. So again, there's a lot of negotiating going on. The other thing is there's a misunderstanding that oral rehydration solutions, if you drink them, they're magically completely absorbed and the diarrhea goes away. No, that's not true. It doesn't affect the diarrhea much at all. And in fact, in some, it can make it worse. We'll talk about that in a minute. So if we had a poll, I would like to see hands, but I can tell you that in every single talk I've asked this question, I've yet to have anyone say, oh, I would way rather take 20 pills a day instead of 4. So I'm going to answer for you. Why do I bring this up? Because the pill burden can be very problematic in these patients. And the reason is that when you're looking at the total number of pills these people are on every day, not only can some of the medications they're on increase diarrhea output, think of all the fluid they have to take all these pills with, which will also increase output. So that's why I always am talking about the total pill count with the clinicians that I am working with when I'm consulting on these patients. And I periodically do the total pill count, and I will remind them, this is how many pills they're taking a day. And many of the clinicians, when I report this, they're like, I can't even imagine taking that many. And I'm like, I can't either. You got to get rid of some. You have to include the prescription, all the over-the-counter, and the supplements. Sometimes the patients I see in clinic that are having the problems, it's because of the sheer number of supplements they're taking that all these people have, quote, helped them and advised them, and they've added them to their, all the stuff they're taking. And that's what the problem is right there. So it's really important that you know everything that's going in their mouth. Dosing is everything. If you want to mean business for a medication to get the job done, it has to be scheduled, in particular the gut one. We're going to talk more about this. And then always ask, are you getting efficacy? If you're not seeing what the response that the drug should create, then you have to question whether the patient is absorbing it, maybe not utilizing that form, etc. Always make sure the drug is available at the local pharmacy, or your patient's going to get stabilized in the hospital and go home and not be able to get the drug. Are they still needed? That's that reevaluate. And I do look over a lot of the pills, and I will ask if they're really needed at this time or even forever. Some of these patients with new ileostomies are left on drugs that aren't even important to their medical situation anymore. So I will ask that they be reevaluated. Think about the form of the pills, whether, some of them liquid tab capsules, it depends on the patient. Controlled, sustained, delayed, or slow release may not work in these patients. And the sugar alcohols, I want to spend a couple minutes on this because this is how I spend much of my time in the hospital on all of my enterally fed patients, but it also will affect your high output ileostomies and short bowel patients. A lot of times clinicians will think, oh, I'll put them on liquid, they'll absorb it better. The problem is so many of our liquid medications have sugar alcohols. Too often people might think, oh, I know that. I know that some liquid meds have sugar alcohols because I've seen this happen already. And so they focus on the sorbitol. So the pharmacist will say, oh, that doesn't have any sorbitol in it. No, it doesn't have any sorbitol in it, but it's got mannitol or xylitol, and so you have to talk in terms of sugar alcohols, all of them of which can aggravate diarrhea in anyone, whether they have an ileostomy or not. So as far as the antidiarrheals that I use, in some patients, I will ask for a C. diff just to make sure, especially if I think I'm about to recommend a narcotic in a patient or an increase in a narcotic. The other thing is I make sure that the meds are ordered 30 to 60 minutes before meals. If they're ordered with the meal or after the meal, you're going to get that washout effect. I think I have a picture. Oh, no, I don't. It's in a different talk, sorry. So it's very important that the patient take it. And half the patients I meet in clinic have not been told this. And so I'll say, no, you need to take it 30 minutes minimum to 60 minutes. And they're like, how come nobody ever told me this before? Well, if you're in a teaching hospital, you have a lot of different people doing the teaching. So sometimes we have to narrow it down to just a few. The other thing is I make sure it's ordered every 6 or 8 hours, depending on, again, the patient, not QID. I want it going around the clock. PRN orders are worthless. When they've looked at how often PRN orders are given, about 60% are not given. So when I get called into a case, I look to see what's ordered, and if it's a PRN order, I then go to look at the 7th day, how many doses the patients received in a 7-day period, because I know what's going to happen. I'm going to call the team, and they're going to say, well, we have them on gut slowing, it's not working. And I'll say, well, it's not working because it's ordered PRN, and in 7 days, out of the 30 doses they were supposed to get, they've gotten 3. So it's not a medication failure, it's a failure to get into the patient, and no med can work if it doesn't get into your patient. And then the other thing is these patients are getting up at night. And so if a patient tells me, yeah, I'm going to get up, I get up every night, somewhere between 12 and 2, I'm going to say, perfect opportunity to get a jump on your day. Keep that gut slowing med in one of these. I give patients these little pill things from the hospital. Just keep it. Don't be looking for that child-proof lid in the middle of the night when you're tired and sleepy. Just put it in one of these, your med in one of these, crushed if it's supposed to be crushed, right next to your bed with a little sip of water. Go to the bathroom, get back in bed, take your medication, a little bit of water, lay down and let it start doing its job. Best time to start the day with the medication. And then what are you looking for? Well, the stool output decreases too much, then you've gone too far, or the patient is nauseated, has mental status changes, or is speaking. So these are the medications that I most often use. Loperamide is my go-to. I start with that. Here at UVA, we take it to 6 milligrams or 3 tabs QID, or I should say Q6 hours. It does come in different forms. Some of the patients, when they're discharged, I have them crush it. The diphenoxylate atropine or Lomodal, I really hate, but if it works for an individual patient, that's all I care about. The reason I don't like to use it, especially in elderly people, is because it crosses the blood-brain barrier and it can make them a little funny in the head and they don't like it. And so I use it judiciously. And then there's codeine. It's my favorite drug. Unfortunately, it's gotten very difficult in terms of we now have to order it every month for our patients. I often will have it crushed before the patient takes it to increase efficacy. No, I never recommend, nor do we ever use the codeine Tylenol combinations, because you can get Tylenol toxicity, especially if the patient happens to be someone who drinks a little too much alcohol. There's also a few patients that have they're slow metabolizers, but you can do genotyping. We don't do that. And then in patients who are renally impaired, especially if they come in big time AKI and a creatinine of 4.7, I'm going to start them on a very much lower codeine dose than I normally would because it's cleared by the kidney. And then finally, tincture of opium, I only use in those with codeine allergies. And the reason is that it's profoundly expensive. Insurance companies are refusing to cover it. It's not available anywhere. We've sent patients home 6 hours away, and we've gotten a call where I don't do this anymore, mind you, but we used to, and the patient would say, I can't get the tincture of opium. Nobody has it. I've called all the pharmacies where I live. Nobody carries it. And so that is a problem. So we want to make sure our patients have what they need and don't have to drive 6 hours to get it. And the other thing is it tastes awful, and they have to measure it in drops. And I've had a couple patients who had poor eyesight, and they got a different dropper, and they came in a little snowed, okay? So don't want that to happen. A little bit about cholestyramine, and the reason I want to mention this is that I end up taking more patients off of it. Cholestyramine is for people who have a colon, period. When you take out somebody's colon, there's never an indication for cholestyramine, and yet half the people with endoleostomies that I come in to see are put on cholestyramine. Not anymore, but this guy was on it. And the thing about bile salts is that we recycle 95% of them in the terminal ileum, and so in particular, if you've got somebody who's lost a lot of ileum and they can't recycle their bile salts, they end up in the colon. The colon hates bile salts. They're very caustic to the mucosa, and the colon responds by it secretes fluid into itself to try to protect itself, and mucus, it increases contraction, so it moves things along far faster and out, and it hinders water absorption in the colon because it so hurts the mucosa. Classic symptoms of people with bile acid malabsorption, again, in those with a colon, watery diarrhea, bloating, urgency, and fecal incontinence. So again, just if you come across people with an endoleostomy or engeginostomy and they're on cholestyramine, you're working with a clinician that doesn't know what cholestyramine is for, and you have an opportunity to educate. Okay, what about fiber bulking agents? Like cholestyramine, fiber bulking agents are for people with a colon. So if you have an endoleostomy or jejunostomy, there's no indication for fiber. Having said that, if I have a patient who wants to eat a higher fiber diet and they have a jejunostomy or ileostomy, I don't care. But am I going to put them on fiber to do something with their output? No, I'm not. In some people, it will increase viscosity. And so if they like that and they want to do this, I don't care. But what I have seen in clinic are patients who've been told to take, let's say, Metamucil. They're eating poorly, and then they take a dose of Metamucil. It sits in their stomach like a rock, and then they don't eat. And so you're not going to go anywhere with the patient's nutritional status. So that's a patient I would never use fiber on. The other thing is that fiber bulking agents exacerbate water and electrolyte depletion because it binds the water and electrolytes in the fiber, and out it goes. It can increase bile salt loss because it can also bind bile salts. And then you can get entrapment of whole micelles, which can affect fat and fat soluble vitamin absorption. Bottom line is, fiber does not improve hydration. So if I have a patient who is taking fiber, is hydrated, doing well, I'll leave them alone. Not broken, don't fix it. And then I also get questions about Bananatrol, so I'm just letting you know there's zero evidence to support Bananatrol. Okay. What about anti-secretory agents? This is the second thing I'm going to go after. A new ileostomy, especially a loop ileostomy that's higher up, these patients might be they can have a hypersecretory state because of the amount of small bowel they might have lost and the feedback mechanisms that are in that segment that they lost. They might be put on an H2 blocker, which is what I call the small guns. Probably not going to do much for these patients. So one of the first things I will do if I come into a high output ileostomy and they are within 6 months of surgery, I'm going to put them on max dose proton pump inhibitor, BID, twice a day dosing. It does require at least 50 centimeters of healthy jejunum. So if I have somebody who I'm questioning efficacy of absorption and and I'm not seeing the response I'm looking for, I might have the patient put on IV proton pump inhibitors for a couple of days. And if the output drops dramatically, I know there's an absorptive issue with that proton pump inhibitor. We now have, though, the tablets that they dissolve in people's mouths, so that we're really not having to do that much as often as we used to. Proton pump inhibitors long-term can increase bacterial overgrowth. It can increase the risk for C. diff. There are some patients we've had to take off proton pump inhibitors because it was the only way we could fix their hypomagnesemia. This is not common, but there are a few that you might see. And then I always reevaluate the use of proton pump inhibitors every 6 months. And then finally, I want to mention octreotide. I see it way overused in practice. I will see patients put on octreotide before anyone has put them on a proton pump inhibitor. Now, the thing about octreotide is it just shuts down everything. And in fact, there is some suggestion that it may slow adaptation of the new bowel that's there. Okay, so you don't really want to do that. So I only use octreotide as a last resort. It's also very painful and expensive. So what do we need to have a plan for these patients, because again, we want to protect their kidneys. And I'm just showing you some of the things that have been done. I'm not going to go over all of these, but basically what it comes down to is these are reports in the literature of groups that have actually implemented a new plan to try to fix the problem with the readmission rate and the AKI dehydration. And it amounts to better education, number one, closer follow-up after discharge, and sometimes just giving the patient set targets for how much fluid they need to drink. So after I did this review and we wrote the article, we decided we needed to put some teeth into what we were doing at UVA. We got all the stakeholders together, the wound and ostomy nurses, the pre and post-op nurses that worked in clinic with our with our colorectal surgeons, the inpatient dietitian and myself that often sees these patients. We all got together and looked at what we were currently doing or what we thought we were doing. That was really interesting. We spent about 8 months on this project, and what we found out is a lot of the things that everybody thought was being done, like calls after discharge, clinic patients visits after discharge with the wound and ostomy nurse, on and on, it wasn't actually being done. So it was an eye-opener. So we went, okay, we need to decide what needs to happen and who is responsible for that piece. And it went beautifully. Everybody took a role, and it's in progress now. We haven't gone back to look at data, but a preliminary was that we've decreased our readmissions so far. So the diet, we charged the other dietitian and myself, we charge ourselves with one page education. It's actually in the handout for a new ileostomy. We gave every patient leaves with measuring devices, the ostomy, and I'll go back to that. I might go back to that slide if we have time. It's on the next slide, sorry. And then the medications and dosing and when to take, we made sure we shored that up. Okay, every single new ileostomy goes home with one of these. We used to send them with the stool hats. They splash, okay? Patients love these. You can see the marks. They can measure very easily their output, dump it out, and record it. And we have them record the date, the weight, stool, and urine output. And for the first 2 weeks, this is mandatory, and they come to clinic with this information, or my colleague calls them, or I as backup call them if she's can't get to a patient. Everybody goes home with a urinal, male and female urinals, so they can measure their urine output. If I have a patient going home and I don't think I'm not sure they have good measuring devices for the volume of fluid I want them to drink, I will give them from our kitchen. These are liter containers, so that it marks readily on there, and I'll tell them how much they need to drink a day of which particular fluids. Sometimes I use these. If I'm having somebody make an oral rehydration solution, I'll grab these out of clean holding. I dump them out. I cross this off and say, no, I don't want you using this stuff, but I want you to use this container. These are really tight containers to mix stuff in. They shake them up. They can reuse them. Silent nights are great for crushing meds. No, I don't have. I wish I had stock in these because I love these. They pulverize medications very easily for patients with poor dexterity. Mortar and pestle work great. So does a baggie and a hammer. Thing is sometimes stuff sticks to the baggie medication, so they don't get the full thing. So when they're discharged, when we instruct them, we tell our patients, measure both urine and ostomy output. This is a change. Before this project was completed, our patients were taught only to measure ostomy output. And the money is the urine. Because if they can't make enough urine, they are dehydrated, period. It means they can't absorb enough, or they're not taking in enough to absorb enough. Either way, it tells everything to the physician that is following them. If a patient says they're only going to measure one thing, I'm going to say make it the urine output, because that's what's going to drive what we do. We also make sure that they understand the targets. And once I do the education, every day I'll just stick my head in. I don't spend a long time. I'll say, okay, what's your ileostomy output supposed to be every day? What's your urine target? It's just a quick visit, and when they go, they know what those numbers are. I always tell them about 80 ounces a day, 2,400 mils, and then I tell each patient, this is my best guess. If you're drinking this much and you're not making enough urine, you may need to drink more. Or if it drives their output more, we need to know that too, because we need to go after more gut slowing, etc. Once a patient is a documented high output patient, I restrict sugary drinks, foods, etc. Be aware that you have to watch out for sweetened commercial liquid nutritional drinks. If I had $1 for every short bowel, high output patient that I saw in clinic that has been put on Boost or Ensure or other equivalent type drink, and their output skyrocketed, I could retire today, okay? So these patients should not be put on those drinks. Watch out for sugar alcohols, both in medications as well as some of the diabetic foods. And I ask patients to weigh twice a week. If they're dropping weight super fast, they've got to call. So we also give them targets. Your urine output drops less than 1,200 mils for 3 days in a row, you call. Your weight drops, more than such and such in a couple weeks, you call. I want to implement periodic labs every 3 months, 6 months, and annually. We haven't started this yet because there's who's going to cover this. But I think every single new endoleostomy should have a basic metabolic and a MAG every 6 to 12 months for the first 2 years to make sure their kidneys are safe. For anyone I suspect sodium depletion, we'll get a 24-hour urine or a random urinary sodium and send it off and see if it's too low. We know we've got to get more salt in that patient. We do 7 to 10 days phone call with all new ileostomy patients that leave the hospital. They get a phone call from my colleague or myself, and we put in Epic. She's got a smart phrase. We ask the same questions. Have you developed a kidney stone? Have you been to any hospital or infusion center and received fluid since discharge? Have you been to any ER for any reason? Because a lot of times, anyone who goes to an ED, they're going to get fluids. And then because we want to identify those patients that cannot maintain hydration and they frankly need IV fluids, period, at home. They need a central line and IV fluids. Okay, back to our case. So here's what I recommended. I divide my recommendations up into medication considerations, nutrition, hydration. So first off, I said, stop the psyllium. Remember, he was put on all those medications. I said, stop the psyllium, reevaluate the need. When I say reevaluate the need, my actual phone call is stop the loperamide and stop the Questran. So that's sort of what that really is. And then start transitioning the patient to codeine, because this particular guy, no question, he is going to need codeine. His output's way too high. I want it crushed half hour before meals and snacks, and I want it at these times. Why these times? Because I know the unit that he's on when trays are delivered. And I know if I specify these times, he will get his meds a half hour to an hour before those trays arrive. And then he happened to be on oxycodone, and I use this as a codeine won't just slow his gut. It will also act as a painkiller. And so that's why I use it as an opportunity to potentially start decreasing the patient's oxycodone use, because we really don't want people on oxycodone if we can help it. And I just said, reevaluate, basically stop the octreotide. It was way too early to initiate that. Nutritionally, goal weight, keep it at 250. That's where he's happy. If he's happy, I'm happy. I asked him to avoid concentrated sugars and liberalize his salt intake. Hydration, he's to measure both 24-hour urine and stool for 2 weeks and report back. Goal urine output for this guy, he's a stone former, 1,500 to 2,000 mils every day I want him making. I put him on 12 ounces of G2 Gatorade twice a day with a little salt packet, about 1/8 teaspoon. That doesn't sound like very much, and it's not, because this guy, the more he drinks, the more ostomy output he makes. So I had to cut him back. And then we put him on IV fluids every night, 2 liters, and sent him home. And he's done great. So, and I just want to share with you some online resources at our website at UVA. They're free. All kinds of nutrition articles available pertaining to this topic, and under the education link. This is our diet handout, condensed after a new ileostomy. Again, it's a 1-page thing, but this is what our patients get, just as an FYI. The only reason I put this up here is because some of these patients end up being bowel, and this book has been made available by Takeda for free for patients and clinicians, so I just want you to be aware of it. And with that, I will answer any questions that you might have. Thank you.
Wonderful, Carol. Great job. So up first, I'll just go through some of the comments. So Asmus says that in California, Kaiser Permanente has access to medical records of patients, even if they go to another doctor outside of the plan. Opium tincture is an opioid. It is administered very strictly here in California. So many colorectal surgeons order fiber for high output ileostomy as therapy. PPI use long-term decreased iron and B12 absorption. And then Shelby says, you're so inspiring, and she'd love to bring this to her institution. So if there's other questions, we'd love to have them in here, or if Carol, if you want to make any comments back to those comments, that would be great as well.
So, yes, two in particular. Narcotics, they're cracked down here. And the reason the tincture of opium, it's actually not available in very many pharmacies in Virginia, period. So, which is one reason why I do not recommend it. The other reason is that it's super expensive. And I had one patient who I wasn't following. Actually, this has happened more than once, and the patient was put on tincture of opium, and then day of discharge was they had stabilized the patient, and the insurance company said, we're not paying for that. And so I get the call. What do we do? And I'm like, well, it shouldn't have used tincture of opium in the first place, and so it just reminds us that we have to make sure that the drug is available elsewhere for our patients, but also will insurance cover it? And that's become more and more of a problem for everybody. Here, the physicians, any narcotic, it doesn't matter what the narcotic is, our physicians have to do a, oh gosh, my mind is blanking, but they have to do a narcotic use contract with every patient. Our short bowel patients, our high out, it's ridiculous, but they have to do it with any patient that's on narcotics, and they can only give them a month's supply. So it's really a hassle. And it's so sad because I've stabilized so many patients on codeine over the years and given them some life back that they can travel, etc., just by doing that. So, it's one of those things that, yes, it's a hassle, but we still have to do it because it's the right thing to do. Secondly, and there are other codes that we've had to use morphine in some patients because insurance dictated it. So we do whatever we have to do. The fiber, yes, there are colorectal surgeons, there are wound and ostomy. In fact, I've spoken at, I think, 10 wound and ostomy conferences now in the last 3-4 years. And you should see the jaws drop in the audience when I say fiber has no place with an endoleostomy. And I mean, they come up to me in droves afterwards going, how come we were taught that? Everyone tells us that. I said, well, it's not true. So, where, I hate to say it, but you have to understand how the GI tract works, and that fiber has a place in the colon. Our gut flora in the colon ferment it and create short chain fatty acids that are the preferred fuel of our colonocytes. It keeps our colons healthy. It also, makes for a nice microbiome. But for somebody with an endoleostomy, there's no data that fiber is necessary or that it helps. And so those of you who work with physicians and you're trying to change practice, one of the reasons I had the article written that is on your handout on the fiber slide is the data or the lack of data for using fiber in patients with endoleostomies. I have never seen a high output patient be fixed or helped with fiber. It just adds to the pill burden.
Thank you, Carol. So we do have another question. Are there any protein drink supplements that you would recommend that may not increase ostomy OP for patients eating very poorly, or would you push for smaller, frequent meals, snacks between meals to supplement intakes?
It's a great question. I haven't found one. I have, in a couple patients, tried, the new low carb, high protein products that both Nestle and Abbott have. And some patients, we've gotten away with it. In others, it has also driven the output. Of course, as a nutritionist, I always like to start with food. I always ask patients what they typically eat, and I try to meet them there and tell them what of the things that they eat, what would be a great snack. And I try to get them to eat just more food because that's what our GI tract was meant to utilize, and it knows what to do with that. So with protein, what I usually do is I'll encourage them to eat more of those high protein foods. The highest biological value protein is eggs. So if I've got somebody who likes eggs, I will say, hey, if you want to have those at breakfast and dinner, fine. And they're like, what about my cholesterol? I'm like, right now, you're so malnourished. We need to infuse cholesterol into you. Don't worry about your cholesterol. So it's really sort of individualizing to a patient and finding those protein sources that they like. I have one patient who loves cottage cheese, another one, tuna fish. Just find those things that your patient really likes. One patient loved liver. Oh my gosh! But it actually her vitamin A was a little low, so it was actually perfect. So does that help?
Wonderful, thank you. So another comment, Carol, you're amazing. PPIs are being overused and MDs tend to forget to DC. I'm not sure what that means, sorry. I'm certainly seeing bacterial growth. And then another person says, does she use Gattex for her patients?
Well, Gattex is to do glutide. We have used it in one high output patient. It's actually does not have an indication for high output. It's for short bowel patients. Yes, we use it when indicated for our short bowel patients after we have implemented all the things that I've discussed and the patient meets criteria. So there is strict criteria the patient has to meet. But yes, there are some patients who will benefit greatly from that drug.
Thank you. And then it looks like we have one final question to wrap up today. What about protein powders? Any concern with using those?
If it's just a straight, like a whey protein, which is my favorite type of protein because it's got such a high biological value, I would not have a problem with a whey protein powder as long as it didn't have a bunch of sugar and junk in it, and have them mix it into like oatmeal, which would be, any hot cereal is a great, highly absorbable source of carbohydrate. And I like to always have patients have protein with carbohydrate, as I'm sure all of you do. But other protein powders, unless they're high biological value or, if they were mixed with a bunch of stuff, I would tend to stay away from it.
Thank you so much. It looks like we've come to the end of our questions, and we've really appreciated you speaking to us here this morning. Thank you so much. And any last comments, Carol?
No, I thank you, and I hope you enjoy the rest of your conference.
Thank you so much. Have a wonderful day.
All right, y'all too. Bye.
Hi, everyone. I think that Marina is going to come back on and share some things with you. So,
hi, can you hear me?
Yes.
Okay.